All right, good afternoon. Welcome to the Philadelphia Regional Center for Children's Environmental Health, the PRCCEH seminar series. I'm Chen, and I think you all know me, and co-director of the center together with Dr. Rebecca Simmons and Dr. Marilyn Howers. Sunni is a professor of epidemiology in the Department of Biostatistics, Epidemiology, and Informatics in the Permanent School of Medicine at Penn. She recently joined us from epidemiology branch and ICHD intramural program. She is well-known, world-renowned reproductive and perinatal epidemiologist. She's studying modifiable dietary and lifestyle factors in human reproduction. She uses a couple-based approach to conduct preconceptional research, which is not that easy to do, but that is a direction of future reproductive health research. She received several awards from her stellar contributions to reproductive health research and mentoring, including the SPER Rising Star Award and SER Brian McMahon Early Career Epidemiologist Award, as well as the NIH Ruth Kosten Mentoring Award. She's editor of epidemiology. I think she was previous editor of AJA, American Journal of Epidemiology, and also associate editor of Fertility and Sterility. So at Penn, she co-directs the Women's Health Clinical Research Center with Dr. Kurt Barnhart, and her today's talk will be Environment, Nutrition, and Lifestyle, Intersecting Exposures and Effects on Fertility.
I'm really excited to be able to share some of my work on the role of environment, nutrition, and lifestyle. And full disclosure, my research really focuses on the nutrition and lifestyle aspects. But as we'll talk about, these are very uniquely tied to the environment. And that's where I think that there are lots of opportunities. I'd really like to talk about ways that we can collaborate and really figure out the best way to look at these exposures in a more holistic way. And I'll end with a few thoughts on potential methods and ideas for moving forward. So we know that infertility is common. It's estimated to affect about 1 in 8 couples. The treatments are very expensive. They're not always covered by insurance, and they don't always work. So couples are often desperate for ways that they can improve their fertility. One couple is even quoted as saying, "I'll even stand on my head eating pineapple if you say that it works." And pineapple has actually become the symbol of the infertility community. There's this thought that if you eat pineapple on the day of your embryo transfer, it will help you get pregnant. But there is zero evidence that this actually helps. But even still, some recommend taking a supplement just in case it might help. And this scenario is all too common in this area. Patients are asking lots of important questions. They want to know what they themselves should be doing. Should I take this supplement? Is it okay to exercise, drink caffeine? Which personal care products are okay? And really, unfortunately, there isn't a lot of data to provide good evidence-based answers. And so that's really been the motivation for my research program in reproductive health, is really to understand the complex role of these lifestyle factors, what we eat, we sleep, how we move, on a spectrum of reproductive health endpoints, from gynecologic to andrologic health to couple fecundity and infertility, and also effects on infant and child health. Really also with a focus on understanding potential mechanisms of action. And so through looking at different cohorts and these different populations and reproductive health endpoints, hopefully we can more comprehensively address these important questions regarding lifestyle and fertility to really provide this evidence-based guidance. And a lot of my initial work in this area has really focused on gynecologic health and understanding associations with ovarian function. And my work really started, I got interested in this by looking at fiber intake. And this is, what kind of set me on the trajectory to look at nutrition and reproductive epidemiology. So we hear a lot about the importance of a high fiber and low fat diet. It's recommended on all the fertility and pregnancy blogs, but what's the evidence? So just like the pineapple story, there really is not a lot of evidence about fiber and fertility, but there is some interesting and relevant data in the breast cancer literature. So we see that fiber intake is associated with a lower risk of breast cancer. And it was discovered that fiber actually can lower estrogen levels, which provided this link explaining the reduced breast cancer risk. And this relationship has actually been shown to be very consistent across different populations and different studies. And it's thought to work through inhibiting reabsorption. So fiber actually binds to estrogen in the gut. It's then excreted, thus lowering the estrogen levels. And so this important link between fiber and estrogen has been really critical for understanding the role of fiber with breast cancer, and I think can really help us provide insight for understanding fertility as well. And often discoveries in one area can lead to important discoveries in other areas. And that's why I think it's important that we bring all of our collective expertise in environment, nutrition, health to these pressing questions. So we were really curious if fiber might influence fertility through these mechanisms. In a cohort of premenopausal women, we looked at estrogen levels across the menstrual cycle. And you'll see here the women who were eating the recommended levels of fiber, they're shown in orange. They had lower estrogen levels throughout the menstrual cycle. So this was pretty expected based on the prior literature. But we were also able to take it a step further and look at ovulation. So the women that were consuming the recommended levels of fiber above 22 grams per day, they actually had a higher risk of anovulation. So their estrogen levels seemed to be low enough that they didn't ovulate. And so this result was surprising to me. Important caveats. This is the first study to look at this relatively small number of anovulatory cycles, but it really points to a perhaps unintended consequence of fiber intake for reproductive age women. We often tell women with obesity to go on a high fiber diet to lose weight when they're trying to become pregnant. But what if this might actually be counterproductive? And so this really highlighted to me the potential for dietary factors that influence hormone levels to have downstream potential impacts on other reproductive outcomes, and that the timing might be relevant. So there may be certain time points across the life course, like when trying to conceive, that a high fiber diet may not be as beneficial. And so I became very interested in looking at how other dietary factors might also influence reproductive hormone levels and ovulatory function. And we built off this work and we found that several dietary factors are important for reproductive health through these hormonal pathways. And this probably sounds very familiar to many of the environmental epidemiologists here, as these dietary factors are acting like endocrine disruptors in a way. And these dietary factors really are only one piece of a very complicated picture. We know that what we eat is related to our environment and other aspects of our lifestyle, and that these exposures interact in meaningful ways. And so members of our team have also considered these other exposures, highlighting that environmentally relevant levels of metals and mixtures of phenols and parabens are also associated with modest changes in reproductive hormone levels in healthy premenopausal women, demonstrating these endocrine disrupting properties. And these changes could contribute to adverse health effects in women. We have also found that tampon use was suggestively associated with elevated levels of mercury and oxidative stress. And so tampons may actually be a source of exposure to metals and chemicals that has been largely ignored. And so we're seeing the interrelatedness of these exposures and a strong role for these factors to influence hormone levels. But what's really been missing from a lot of our initial work was how these changes in hormone levels might translate into other important outcomes. Do they actually influence couple fecundity and infertility, pregnancy loss? And so we've built on the initial work looking at ovulatory function. We've done several ancillary studies measuring biomarkers related to diet and the environment. And we've identified several factors that are important for establishing and maintaining a healthy pregnancy. And today I want to focus a bit on some of the work that we've done related to vitamin D. And vitamin D is really a unique factor that brings together several of these lifestyle exposures that we're interested in. There's a dietary component. We get vitamin D from various food sources: cheese, margarine, butter, fatty fish, and supplements. There's also potential environmental component. We get vitamin D from the sun. There's a potential physical activity component. And so I think vitamin D is really a great example of one of these factors that encompasses several of these lifestyle exposures that we're interested in. There's also increasing evidence of the importance of vitamin D for reproductive health. Vitamin D receptors are located throughout the reproductive tract. Vitamin D has been shown to have anti-inflammatory properties at the interface of the maternal fetal tissue, been shown to regulate proteins necessary for implantation, and through its immune modulating effects, might be especially relevant for pregnancy loss, because we know that the human fetus cannot survive without maternal immune tolerance. And so through these mechanisms, we might hypothesize that vitamin D could influence the spectrum of reproductive health outcomes. And I've been especially interested in the role of vitamin D on fertility and pregnancy loss. Vitamin D is a part of the fertility treatment workup in many clinics. And I have to admit that I've been a little bit skeptical, wondering if vitamin D is measured as part of this workup because it actually matters and it's important, or is it, just to charge an additional $100? We hear a lot about vitamin D, and sometimes I think it sounds a little too good to be true. And so I wanted to dig into this a little bit, looking at fertility and loss. And there's some interesting ecologic data that suggests a role of vitamin D. So the total fertility rate tends to be reduced in these higher latitude countries where vitamin D levels tend to be lower. But what about measured levels? Well, there are lots of studies that have been done in pregnant women, but these are unable to address live birth rates. So in order to calculate live birth rates, we need to know just not how many people became pregnant, but also how many people were trying and weren't successful. And so the IVF literature sheds some light on this, and we do see that vitamin D levels in serum and follicular fluid might be predictive of success of IVF treatments, but this doesn't really tell us about fertile women. We know that the populations are different in many important ways. These studies in pregnant women tend to recruit during the first trimester, and so they're not really able to look at effects on pregnancy loss. And to just put this in perspective, about 50% of the losses occur before 8 weeks, and 85% occur before 12 weeks gestation. So these studies that are recruiting 10 to 12 weeks gestation, they're not just missing some of the losses, they're really missing most of the losses that are happening. So this really highlights the need for preconception studies so that we can calculate these live birth rates, know who is and who is not able to have a live birth, and also to be able to detect these early pregnancy losses that are happening. And the EAGER study is really well positioned to be able to address these types of questions. EAGER is a prospective cohort with preconception recruitment. It included over 1,200 healthy women with a history of pregnancy loss. They have no diagnosis of infertility. They were followed for up to 6 cycles while they were trying to become pregnant. And if they became pregnant, they were followed throughout their pregnancies. We measured vitamin D levels at baseline to really get this preconception measure. And then we also measured vitamin D again at 8 weeks gestation in the women who became pregnant. And we measured 25 total 25 hydroxy vitamin D, as well as several markers of vitamin D metabolism. And about half of the women in the study had sufficient levels based on the IOM guidelines. And these women tended to have lower BMI, be of white race, have higher income, and report higher levels of physical activity. And so we're really interested in a couple of main questions. So the first, what are the effects on fertility, on live birth? And I like to think of this as couples decides they want to start trying, go to the gynecologist. What's the association between vitamin D and my likelihood of a take-home baby? Compare that to looking at pregnancy loss. So given I'm able to get pregnant, go to your OB. You have a pregnancy test, go to the OB. Given that I've been able to become pregnant, what is the association between vitamin D with my risk of pregnancy loss? And so we were able to look at both of these questions. And here we're looking at sufficient versus insufficient vitamin D based on these IOM cut points. And we see that those who had sufficient vitamin D tended to have higher pregnancy and live birth, but lower risk of pregnancy loss. And we looked at this also per 10 unit increase in vitamin D, and we see the same pattern: higher vitamin D, more pregnancies and live births, and lower risk of pregnancy loss. So this was very intriguing to me. This is some of the first work to look at preconception levels and these outcomes. And I think with any research question, it just raises a lot more questions, which is the fun part of doing research. So I started to think about a few different things. So what's the best cut point? We've been basing most of this on these IOM cut points that have been developed based on bone health. But is that the right level for reproductive health outcomes? We know that preconception is an important time period, but it's very hard to capture women during the preconception period. About 50% of pregnancies are unplanned. So what if we're not able to assess vitamin D levels during preconception? A woman comes in at her first OB visit. Should we be measuring vitamin D then? Will that tell us something about her risk of pregnancy loss? Also, are we using the right biomarker for vitamin D status and metabolism for understanding these relationships with reproductive health outcomes? Be handling this environmental component that we haven't talked much about so far. We know that we get vitamin D from the sun, but how does sun exposure, sunscreen exposure play into this? And should we be getting our vitamin D from supplements or the sun? So we looked at each of these questions in a little bit more detail. So in terms of the best cut point, these are the results that I presented earlier. So this is the IOM cut point based on 30 nanograms per milliliter. And we also considered other cut points, 20, 40, 50. And you'll see for live birth that the results are pretty much the same. It doesn't seem to make that much of a difference. But for pregnancy loss, there's some indication that higher levels of vitamin D might confer an even greater reduction in the risk of pregnancy loss. So this might be suggesting that the IOM recommendations are potentially appropriate for live birth, but that higher levels may actually be needed to decrease the risk of pregnancy loss. It's kind of highlighting the need for additional studies so that we can really hone in on what the right cut point should be. What about early pregnancy levels? Well, here we're comparing our preconception levels. We see that at preconception, higher vitamin D is associated with a reduced risk of pregnancy loss. And then we also looked at this early pregnancy time point at 8 weeks gestation. And the results are very much attenuated. So this might mean that there's something going on with very early pregnancy losses. You know, maybe we missed the window of vulnerability By the time we get to 8 weeks, it's just too late. Could be a loss of power because we have fewer events at this time point, but really highlighting that the preconception time period is important, and we need to be focusing on preconception where we can. What about biomarkers? So total 25-hydroxy vitamin D is by far the most widely used marker to determine vitamin D status. When you go to get your vitamin D tested, this is what's being measured. But there's been considerable debate regarding whether this is the most appropriate measure to reflect the biologic functions of vitamin D, and whether free or bioavailable might be a more accurate measure of vitamin D status. The vitamin D binding protein may also be a critical player in this. It's the main carrier protein of vitamin D in circulation. It's influencing bioavailability for target tissues, and polymorphisms in the vitamin D binding protein gene contribute to differences in vitamin D status. We can look at the components of total vitamin D. It includes this vitamin D binding protein bound portion, which is the majority. It's about 85 to 90%. There's also the bioavailable portion, which includes the albumin bound and the free vitamin D. And the vitamin D binding protein bound compounds are really thought to have limited effect on most target cells, and that it's really the bioavailable or the unbound vitamin D that's physiologically active. And so there's a thought that this may be a more accurate determinant of functional vitamin D status. So several studies have implicated vitamin D binding protein as being indirectly related through its influence on bioavailability, but there's also some evidence that the binding protein levels themselves might be important as well. The binding protein is involved in chemotaxis of molecules like fatty acids and endotoxins, and it's thought to be important for fertility because of its immunomodulatory properties. And there have been a few studies that have started to look at this. It's really quite a new area, but there's really a need to delineate the potential use of the binding protein as a biomarker for fertility and to clarify its role as a measure of vitamin D status. There are also other markers involved in vitamin D metabolism and calcium homeostasis that might be relevant. So the renal synthesis of the active form of vitamin D, 125, are really tightly regulated by parathyroid hormone and fibroblast growth factor 23. But really, we don't know a lot about how these markers may be related to fertility. So perhaps not surprisingly, when we started to look at these levels, the women who had higher total vitamin D also had higher individual components. So they had higher free, higher bioavailable vitamin D, and also higher binding protein concentrations. And the women who had higher binding protein tended to have lower free, lower bioavailable components, but also had this higher total level overall. And so in our original work, we showed that women with higher total vitamin D had a higher percent live birth. So this is similar to the results that I presented earlier, but here we're comparing the first and the fourth quartiles. And we're doing this because these other markers of metabolism don't have standard cut points. So this is very similar to the IOM cut point analysis from before. So we know that the total vitamin D is broken down into the vitamin D binding protein bound and the bioavailable components. So we looked at the binding protein itself. We really saw no differences in live birth by level of binding protein. But we do see that the bioavailable and the free vitamin D may be important. Those with higher levels also had a higher percent live birth. So suggesting that maybe the binding protein may not directly be influencing live birth, but perhaps indirectly through its effects on bioavailability. And when looking at the other markers of vitamin D metabolism, we found that women with lower PTH, they also had a higher percent live birth. We did not see associations with FGF23 or calcium. And so these results are really highlighting that the functional vitamin D status may be relevant. We're not seeing associations with the binding protein itself, but there are strong associations with free and bioavailable vitamin D with both live birth and pregnancy loss. And we also found that PTH may be a useful biomarker. PTH is important for stimulating synthesis of active vitamin D. And there have been some recent studies showing links between PTH and polycystic ovary syndrome, which may suggest its relevance for other reproductive endpoints and really highlights the need for more research here. And so in moving forward, we really need future studies that are incorporating these other biomarkers as well. What about the environmental component? So in considering the role of the environment, we unfortunately did not have information on sun exposure or sunscreen use, or whether they tended to exercise outside. Strength of the study was that we have serum levels measured of vitamin D. So we have a good measure of their actual vitamin D levels, but we don't know the source of their vitamin D levels. After the original study, we were able to measure phenols and parabens. And so we've gone back and we adjusted for these chemicals as a way of starting to get at whether these associations we're seeing, if they might be related to sunscreen exposure. And thankfully our results were similar, but I don't think this is as straightforward as this. So I'm not sure that we're adequately adjusting for the right thing. Should we be considering other chemicals? And what's the best way to really account for this? And this is where I'd love to get your ideas on the best way to tackle this question. And really, unfortunately, based on these findings so far, we can't really tell whether we should be recommending vitamin D from supplements or from the sun. And I think there's really a great opportunity here to more fully consider the role of the environment, diet, and lifestyle exposures on these various components of vitamin D. Emmett, do you have a question?
Yes, the question is about like benzophenone 3 is probably a better indicator of sunscreen exposure. So I think your phenols, does your panel actually including that? That's my question.
Yes, as far as I know, we were able to account for BP3.
Okay, good. Thanks.
Thank you. Okay. So we have done some preliminary work accounting for environmental factors, but really I think there's a lot of opportunity to explore this in more detail. So our work is really demonstrating the role and the importance of preconception vitamin D on fertility and pregnancy loss. But why? So could it be effects on these gynecologic health factors, something else like inflammation? So I was very interested in trying to understand some of the potential mechanisms. Could it be due to influences on oocyte quality or quantity? Or these hormonal factors that we know are important for establishing and maintaining pregnancy? Or what about inflammation? So we hear a lot about the role of inflammation on adverse pregnancy outcomes and pregnancy loss. There's also evidence that male embryos are more susceptible to inflammation. So one way to look at the potential effects of inflammation is on the sex ratio. And vitamin D might be important here through its anti-inflammatory effects. And so we have tried to explore each of these potential mechanisms in a little bit more detail. First, in terms of oocyte quality, we looked at anti-Mullerian hormone. AMH is part of the initial fertility evaluation. It's a marker of ovarian reserve. The blood levels of AMH are thought to reflect the size of the remaining egg supply, and it's an indirect measure of oocyte quality. The levels naturally decline as a woman ages, and there are different fertility pop-ups that come up that will say, ask if you want a biomarker for your fertility. What they're looking at is the AMH levels. And there are some in vitro studies that actually suggest the ability of vitamin D to influence AMH production. And so we looked at associations between AMH and vitamin D and really didn't find anything. It did not seem to be that the associations with fertility are likely being influenced by effects on AMH. And other studies have also started to show this as well. So that it's not likely through oocyte quality or quantity. But what about hormonal regulation? So vitamin D actually can regulate FSH receptor expression. And the presence of the vitamin D receptor in the ovarian granulosa cells really provides a mechanism through which vitamin D could directly modulate estrogen production and influence these processes. And there are some experimental studies that show that vitamin D can regulate ovarian steroid production. And on the epidemiology side, there's some studies showing that low vitamin D levels are associated with longer menstrual cycle lengths. So really suggesting that there could be a potential hormonal mechanism involved. So we were able to look at a panel of reproductive hormones measured a few times throughout the menstrual cycle. And we found that vitamin D was associated with FSH and E1G, an estrogen metabolite, also the free androgen index and sex hormone binding globulin. And though we see these associations with hormone levels, we did not see associations with anovulation. So these are relatively modest changes in hormones. But they are suggestive of an important role of vitamin D in the hypothalamic pituitary ovarian axis, particularly with FSH and the bioavailability of androgens. And like I said, these changes we observed were within the normal ranges. So we are seeing some potential hormonal regulation as a potential mechanism. But what about inflammation? So our findings are really suggesting that the preconception period is important to consider for pregnancy loss. So this maternal environment during preconception around implantation may be important. Inflammation has been shown to have a detrimental effect on many pregnancy complications, and male embryos tend to be more susceptible to inflammation. So it's possible that we could look at the role of inflammation on this maternal environment and implantation through looking at effects on the offspring's sex ratio. And we see some potential population level evidence of this when we look at trends in the sex ratio over time. So the usual sex ratio is about 1.05, which means that for every 105 males that are born, you tend to see 100 females. And as shown here, the sex ratio has tended to decrease over time. Why this is happening is not totally clear. It's likely due to multiple mechanisms. And we actually tend to see more drastic declines with parental exposures to certain environmental hazards. So they've shown links with the sex ratio with smoking, dioxin, methylmercury, earthquakes, and these toxic chemicals and stress seem to be particularly hazardous to male conception or survival. And one potential mechanism to explain these differences in the sex ratio could be through maternal inflammation that really tends to show these sex-dependent embryonic effects. So if there's a role of inflammation, is there a role for anti-inflammatories to really counteract this influence on the sex ratio? And so in some of our prior work, we did show this link between inflammation and fewer male offspring. And we found that low-dose aspirin, which is an anti-inflammatory, started preconception, actually restored the sex ratio to the normal level. And we hypothesized that this is through modulating inflammation. And so I was curious if there might also be a similar role for vitamin D, given that vitamin D also has anti-inflammatory and immune modulating effects. So we were intrigued by some ecologic data that suggests a potential role for vitamin D in the sex ratio. So latitudinal, altitudinal, and temperature sex ratio gradients have been observed, but no one had really looked at the role of vitamin D directly. And so that's what we sought out to do. And when we look at the sex ratio, we're usually measuring the secondary sex ratio at birth, but we know that a lot of steps have happened before we get to this point. We know that not all women who become pregnant have a live birth, and that about 30% of pregnancies end in a pregnancy loss. Among fertilized embryos, not all are successfully implanted and result in a recognized pregnancy. And not all women who are trying to become pregnant are successful. And so this sort of selection process or funneling of events that happens from preconception to live birth, we see in a lot of areas, especially in reproductive epidemiology. We're not able to observe each of these events, and so that has some implications on the questions that we can answer and how we answer them. We also know that the sex of the embryo is determined early on. There's an interesting IVF study that shows that the sex ratio at fertilization is about 50-50. And so something seems to be happening during this implantation process or during early pregnancy that is really resulting in, that leads to this 1.05 sex ratio that we're seeing at birth. And it's possible that vitamin D could play a role at each of these steps through its anti-inflammatory properties. And so we were interested in looking at the role of vitamin D at these different time points. And there are really 3 points of this process that we're able to observe. And the first, we're really interested in understanding the role of preconception vitamin D on male live birth through all of these processes. So this is kind of what I like to think of as the influence in the real world setting, where some women will conceive, some won't. But what's the total effect of vitamin D on male live birth through all of these processes? You could also look among the women who conceived. And here we would remove any influence of vitamin D on implantation through inverse probability weights or some other approach to account for the selection bias by looking at those who conceived. And we could do the same thing looking among women who had a successful live birth. So removing this selection that happens between implantation and live birth to estimate the effect among the women who had a live birth. So really interested in the role of vitamin D on the sex ratio and evaluating whether these might differ by inflammation status. So here is the results by vitamin D status. We have 51% male live births in the sufficient vitamin D group, the solid orange, and 46% in the insufficient group. So we are seeing that vitamin D seems to be associated with an increase in the percent male live birth. So really suggesting that there's an influence on the sex ratio. And so this is the role of vitamin D on live birth through all of these selection processes that happen from implantation to live birth. And when we look at this by inflammation, so we looked among those with high inflammation based on CRP, which is a marker of systemic inflammation. And we see that those with high inflammation and insufficient vitamin D, they have an even lower percent male live birth, but that the sufficient vitamin D levels seems to bring the percent male live birth back up to 50%, where we would expect it to be. And in the low inflammation group, the sex ratio is closer to what we would expect overall. We don't really see any associations between vitamin D and the sex ratio in the low inflammation group. And so what this means is that it looks like sufficient vitamin D levels are actually restoring the sex ratio, bringing it back up to what we would expect, even among women with high inflammation. So it seems that vitamin D is potentially mitigating the harmful effects of inflammation on male embryos. So this work is really suggesting that inflammation is important for male conception and survival, and that this can affect the sex ratio of populations. Importantly, we should not be interpreting these findings as a method to influence infant sex on an individual level. So we're not recommending here to be in the sun, to have a son, but we are showing the importance of inflammation on this process. So this work is really highlighting the role of vitamin D as a novel factor influencing the sex ratio through modulating inflammation. And together, this work really demonstrates that preconception vitamin D, this factor that encompasses environmental, lifestyle, and dietary exposures, is really important for establishing and maintaining a healthy pregnancy. We see that we might need higher levels to prevent pregnancy loss, that considering the preconception period and windows of susceptibility is important, that we should try and integrate the functional status of vitamin D, and that we need to be considering the role of the environment, and that this may be working through hormonal mechanisms and through modulating inflammation. And so even though I was skeptical at first, I like to consider myself a data-driven person, and I'm pretty convinced that vitamin D plays a role in fertility and pregnancy. So now what? There's a lot of work to be done. There's still lots of unanswered questions regarding vitamin D and these other endpoints listed here. And our team is starting to work on those. But this work also really needs to be replicated in other cohorts. And so we're working with the Prepared Consortium, which combines all of the preconception cohorts. And this will allow us to do a couple of really important things. So first, we'll be able to look at a wider range of vitamin D. So hopefully this will help us figure out what that optimal level is for reproductive health endpoints. And perhaps most importantly, you may have noticed that I haven't really touched on diversity at all. And unfortunately, this cohort has very limited diversity, which is a significant limitation of the work that I've presented today. And so in working with the consortium, we'll be able to evaluate these associations in more diverse populations, which is especially important given the known interplay between skin color, genetics, and vitamin D metabolism. And I also think that there are several opportunities for improving the methods in this area and our ability to look at these exposures together. And so I'll talk just very briefly about a few of these potential methods considerations. I think that there's really a need to integrate causal inference to address these important questions. And this is where we need to be working together, bringing our collective expertise to draw these directed acyclic graphs that incorporate the multiple factors that we're interested in. And this will likely require use of G methods or some other appropriate method to account for time varying confounding and to account for the interplay between these different environmental and lifestyle factors. I also think we need to start thinking about mixtures. I think the environmental epidemiologists are doing a great job of incorporating these methods when considering environmental chemical exposures. But so far, like with diet, we're considering these all individually. We're considering the chemicals separately, each component of the diet separately, and then physical activity and sleep. Each is distinct exposures, but we know that they're related. And so one way to think about this is to consider this as a lifestyle mixture and extending the methods that are being applied for environmental chemicals to include other lifestyle and dietary exposures as well, to really start considering these broader mixtures of environmental and lifestyle factors. And I don't think it's totally clear how we do this in a mixtures context. So I've been starting to think about this in a very simple way with sleep, exercise, and sitting. So thinking about those as a summation of a day. And wearables and other technologies really give us the opportunity to think about whole day activities that are dependent on one another. And we can build off of that to add in the dietary exposures, which are themselves mixtures, but aren't usually handled as a mixture, and adding in the environmental exposures and mixtures as well. And so we need to be working to develop and apply statistical approaches to handle these lifestyle exposures to really figure out what the appropriate fertility lifestyle mixture is. Next, I think there's also an opportunity to implement trial emulation. So randomized trials of lifestyle interventions are very challenging for a number of reasons. So it can be very difficult to define the intervention itself. So which lifestyle factor do you want to focus on? Duration, intensity, and also to have the sample size large enough to detect what are often very modest effects. And one thing I haven't really touched on yet with regards to fertility trials is that if you want to look at the preconception period and those critical windows of development, you need even bigger sample sizes. So if you start with 1,000 couples, only half will get pregnant. Even fewer will have pregnancy complications. And then if you want to look at effects in the children, which we're all interested in, the numbers get small really, really quickly. There's also a lot of non-compliance when looking at lifestyle interventions and figuring out the best population to study and really recruiting a generalizable and diverse population. And these trials can take years to complete, and they're very expensive to fund. And it would be near impossible to really do a lifestyle intervention trial to compare all of the lifestyle factors that we want to vary, or to be able to do it with a big enough sample size to detect effects. And trial emulation really gives us an opportunity to use the observational data that we have, and perhaps combining across the cohorts that we have to really address causal questions of interest to help guide public health and medical decision makers so that we can ask these important causal questions and be able to translate these findings into meaningful messages. And we've started to apply some of these techniques for dynamic treatment regimes to look at different lifestyle interventions to prevent pregnancy loss. And so this work was led by a postdoc fellow in our group, Dr. Alexander Purdue-Smythe, who's now on faculty at Brigham and Women's Hospital. And we've been looking at questions like, how many pregnancy losses could be prevented if women change their exposure to smoking, alcohol, and caffeine? How early should women change their exposure to these factors to maximize risk reduction? So really getting at this important issue of timing. And which interventions require the fewest women to change their behavior? So which are really most likely to work in practice? And so we defined several hypothetical interventions, starting with single interventions, but then considering joint interventions as well. About extending this to other environmental and lifestyle factors as well, to consider interventions that incorporate exercise, sleep, diet, environment, and using wearables, other technologies to define these detailed interventions, get at these windows of susceptibility that we're interested in to really understand the role of lifestyle on key questions related to fertility and health. Lastly, especially for fertility outcomes, it's very important to consider both partners. And so we need methods to be able to evaluate the role of these lifestyle factors in both partners together. And we have a study that we recently finished where we have data from both partners. And so we're working on figuring out the best way to incorporate these couples-based approaches. So overall, we're seeing that lifestyle factors, and especially vitamin D here, are very important for reproductive health. They're influencing hormonal pathways that are really critical for downstream outcomes like fertility and pregnancy loss. And the timing is important. There's a need to consider preconception exposures. I think far too much of my own work has been on considering these exposures individually. And so I'm working on trying to figure out the best way to consider these exposures together to figure out these lifestyle mixtures that are relevant. But I can't do that by myself. And so I think that's where we really need to work together. We have an incredible opportunity to move the field forward, both ideologically and methodologically. And so by thinking about these new methods and applying novel methods to address these questions, and I look forward to some new and exciting collaborations with all of you, because really the goal is to provide the best data for evidence-based guidance, so couples are not left to rely solely on the pineapple. And this work really takes a village. I want to thank the current and former fellows that have worked on our team, for my colleagues in the NICHD for funding this work. And thank you so much for your time, and I look forward to any questions.
Thank you, Sunny. This is excellent talk, and really, we all need vitamin D for sure, but so yeah, timing is really important. So, any questions for Sunny? I think we're Becky first.
Sunny, that was a really interesting talk. You answered one of my questions, which was, did you control for a race? And obviously you couldn't do that. You said just because the numbers were low. But I wondered, and Black women have historically much lower vitamin D levels and higher rates of infertility. I also wondered, though, did you factor in BMI? The same kind of issue is that obese women have lower vitamin D levels and do have much higher levels of infertility. So I didn't know if you could factor that in as an additional risk factor on top of.
Yeah. We did adjust for both race and BMI, but I think to your point, perhaps also stratifying by BMI to see if we're seeing different effects in the different weight groups, I think would be really important. But we did account for BMI in all of these analyses. And we're working to try and develop some new cohorts at Penn to really recruit some diverse populations, because it's so lacking, especially in the reproductive health space.
Yeah.
And I'm convinced that vitamin D is important in this population. And I'm curious how that extends to other populations where it could be even more important, So I'm hoping that we can do that.
All right, Trevor.
Yeah, great talk, Sunny. So a comment and a question. You indicated, as did Becky, how it would be important to do the study in African-American women because of their skin pigmentation and inability to make as much vitamin D. But I can't believe there aren't reference levels of vitamin D in African Americans that one could actually start as a starting point to see where they're at vis-a-vis what you're seeing in Caucasian women. And I can't also believe that there isn't some clinical data on African Americans and pregnancy outcome, and where they've actually had vitamin D levels measured. So maybe the data you're looking for is already in the public domain. It just needs to be found.
That's a good point. There is a lot of data showing that the levels of vitamin D deficiency are much higher in Black populations. That's been demonstrated in pregnant and non-pregnant populations. And they have looked at associations with pregnancy outcomes, looking at levels during pregnancy. And so there are similar relationships with pregnancy complications and vitamin D levels during pregnancy. The preconception period really hasn't been addressed yet because it's much harder to recruit those populations just in general. But that's where I think the big data gap is, because there is a lot of evidence showing the higher rates of deficiency and links with pregnancy complications. in
So-
these populations.
So actually, we have been collaborating with people at the University of Illinois and looking at vitamin D status in prostate cancer in African Americans. And those studies show that, as you might imagine, African Americans actually have lower vitamin D, and we also know they're more susceptible to prostate cancer than our Caucasian men. It's about twofold difference. And what our studies showed was that decreased vitamin D increased a testosterone transporter called megalin, and that megalin causes increased androgen uptake in target tissues. So I'm wondering if there is some commonality in mechanism whereby changes in androgen transport mechanisms might actually be a reason or contributing reason to why you're seeing these effects on infertility.
Yeah, that when we were looking at the hormone levels, we see it the most with the androgens
There you go.
and the bioavailability of androgens, which matches up exactly with what you're saying. So yeah, I think that there is something there.
Yeah,
That's interesting.
yeah. And my other question for you is, you as your biomarker for inflammation, you use CRP, which is not necessarily, as you probably are aware, not the best biomarker of inflammation. I'm wondering if you thought about measuring more robust biomarkers of inflammation. One is often used to measure prostaglandin E metabolites in serum and in urine. I wonder if you thought about doing that as a corollary to measuring inflammation.
We need to look at that. We've recently finished a large panel of cytokines. But yeah, we need to look into that. We have some stored samples so we can
Well, we can
explore this a little bit more. Yeah.
Anyway, great talk. Really enjoyed it.
Sunny, my only question is about like seasonality. I think vitamin D is related to seasonality, and you have vitamin D difference. You also have dietary source of vitamin D. So how much of the difference is really explained by seasonality, or how much of the difference is actually so it's not related to season? So did you see the patterns similarly for vitamin D, preconception of vitamin D for people who actually can conceive during the sunny, more like summertime versus winter time? So that is just like my thinking about it, like how to differentiate that actually, because seasonality is not only sun, it's more than sun anyway. So yeah.
Right. So we did adjust for season when the vitamin D levels were measured. And so the results I presented are adjusted for season. If that's like with the BMI and race, I'm always unsure if these traditional approaches for adjustment are adequate to really get at this. But we did see, because we have the group that got pregnant, we have vitamin D preconception and at 8 weeks gestation, and there's usually a few months in between. And we do see that the levels on average don't change very much, but there is an expected decline when you go from summer to winter. And then we do see the increase in vitamin D levels from winter to summer. They don't change drastically, but we do see that, and we did try and account for that here.